Hi, everybody. My name is Adam Lipworth. I am the chair of dermatology at the Leahy Hospital and Medical Center in Burlington, Mass. And we're going to be going through some key dermatology cases for the internist today. I'll leave this up for just a moment so you can read it if you'd like. And I have no disclosures, but we will be discussing some off-label use of medication today. So we're going to use case vignettes to go over everything that we're going to discuss today. I'm not going to read the slide because, frankly, the more you know about the cases in advance, the less fun this will be. I'd like these to be unknowns as we go through. So I've left it up there for a moment, but now we're going to move on straight to case number one. So the picture here is of a 54-year-old woman. This is her forearm. It's 5 days after excision of a basal cell. And she has progressive peri-incisional redness and pain, so a little bit of malaise, a low-grade temperature. Now, I'm not going to ask you what this is. We all know what this is because it has a purple line around it, the universal sign for cellulitis. And indeed, this is cellulitis. Okay? My question is this. Which of the following characteristics is most sensitive for cellulitis? Meaning, if you don't have one of these, you don't have cellulitis. Tenderness, fever, leukocytosis, pruritus, or malaise. Which one of these, if you don't have it, does that mean you do not have cellulitis? Think about it for a moment. And the answer here is tenderness. This is probably the most important message for today's talk. Cellulitis is tender. When you mash on it, it hurts. So we'll go through a lot of points today, but that's probably the one to keep most ingrained. Now, the reverse is not always true, right? So not everything that is tender is cellulitis. There are lots of things that are tender. But if it is not tender, you know it's not cellulitis. It's a highly sensitive characteristic. So management of cellulitis. I would argue that the first step, well, we're often thinking about whether to cover MRSA or not to cover MRSA. That's often for the management of simple outpatient cellulitis, that's often what we're thinking about. But I think the first step is simply to think, is this cellulitis or is it not cellulitis? And then we get to, is it severe or is it not severe? And then we get to, if it's not severe, which antibiotic do we choose? Now, the reason we start with cellulitis versus not cellulitis, it's not just intuition. It's because there is substantial data that cellulitis is overdiagnosed. It's also sometimes underdiagnosed. There's a sensitivity and a specificity issue around the country. But this paper and a couple others that came out around the same time are focused on the overdiagnosis, people being fooled by pseudocellulitis, by cellulitis mimickers. In this particular study, which was done at Brigham and Women's Hospital and Mass General Hospital, they found that 259 patients who were admitted from the ED with cellulitis, 30% of them actually, with the benefit of hindsight, did not ever have cellulitis. And 17% of those patients never required admission in the first place out of those 259. If you extrapolate that to the entire US population, that's about 50 to 130,000 unnecessary admissions per year, $200 to $500 million in avoidable healthcare expenditures. So this is an algorithm that I use personally when I'm evaluating somebody for the possibility of cellulitis. The first step is a tender. If it's not tender, immediately consider alternatives. If it is tender, then is it bilateral, especially bilateral symmetrical? Remember that the bugs on one leg can't communicate and coordinate their efforts with the bugs on the other leg. So the left can't talk to right. So if you have a rash that is progressing symmetrically up both legs at the same time, it is very unlikely to be cellulitis, almost impossible. Not quite impossible, but bilateral cellulitis is very, very, very rare. If it's bilateral and symmetrical, consider an alternative like stasis dermatitis, for example. Is it pruritic? Cellulitis can be itchy at certain points in its natural history, but it's usually not the primary symptom and certainly not at the beginning. At the beginning, it's pain and tenderness. If it's very itchy, think about an alternative. And then is it geometric? Is it a special shape that our bodies shouldn't be able to make on their own, like a perfect square, a perfect triangle, right? That is a sign of an outside job, something that touched the skin that was that shape and therefore caused a rash like an allergic contact dermatitis. So these pictures here are all pictures of mimickers of cellulitis, of pseudocellulitis. Notice here this perfect rectangular shape. And this was an allergic contact dermatitis to mastosol, actually, that would have been used in a dressing. Okay. Step number two, consider the severity, because if it appears to be a severe infection, the patient is very ill appearing or has severe comorbidities or has evidence of a deep infection necrotizing fasciitis, those patients are going to be admitted or at least observed very carefully, debrided if needed. They're given broad spectrum IV antibiotics. You're not trying to be elegant and try to cater the antibiotics to a specific bug. You're going to cover very broadly. Somewhat counterintuitively, the management of simple cellulitis involves some more difficult or complicated choices about which antibiotic to choose, because you're going to treat orally and you want to be more elegant with that. You don't want to treat more broadly than is necessary. So which antibiotic do you choose? Remember that the common pathogens are group A strep, methicillin-sensitive Staph aureus, and community-associated MRSA. Methicillin-sensitive Staph aureus and group A strep will be susceptible to beta-lactams. Not necessarily all beta-lactams in the case of MSSA, but at least the late generation semi-synthetic penicillins and the first generation cephalosporins will get all strains of MSSA and group A strep. MSSA and community-associated MRSA are generally still susceptible to the sulfa agents, trimethoprim sulfamethoxazole, but group A strep is not reliably susceptible to trimethoprim sulfamethoxazole. As an aside, trimethoprim sulfamethoxazole is probably a little better for group A strep than we give it credit for, but it's certainly not anywhere near 100%. And then susceptibility to all the other common classes of antibiotics is going to vary for all of these bugs, for group A strep and then all forms of staph. So that's Clinda, fluoroquinolones, tetracyclines, macrolides, and so forth. Now, there are certainly some oral antibiotics that are going to cover pretty much all of the common causes of cellulitis, like linezolid, for example. But we don't want to be giving linezolid to every simple cellulitis patient that walks through the door. I probably don't need to explain why to this audience, but not least, the reasons not least of which are you don't want to be the doc who created Lursa. So cultures are usually not going to help you. They're usually very low yield. Only about 15% of patients will ever culture positive from blood or skin from their cellulitis. And that's probably a very special 15%. There's something unusual about that 15% that makes them probably not generalizable to the other 85%. So here is a tour of the data about which antibiotic we should use. And I'm going to go back as far as 2010, when there was a Cochrane review that tried to answer this question, and they could draw no conclusions at that time. 2013, we actually started to get some decent data. This was a trial done at Brigham, Mass General, and Children's Hospital. And they randomized, they took 153 consecutive patients with simple cellulitis that came in to the EDs. All of them received trimethoprim, all of them received cephalexin. And then they were randomized to receive either trimethoprim sulfamethoxazole in addition or placebo. And they found no benefit to adding the sulfa agent, which covers MRSA much better than, well, it covers MRSA. The cephalexin does not. No benefit to adding the anti-MRSA agent. That same study essentially was repeated in 2017, different group, much grander scale. This was across the US, 5 different emergency departments, over 500 cases now of simple cellulitis in the EDs, and they were again given cephalexin or randomized to receive either trimethoprim sulfamethoxazole or placebo, and they found almost exactly the same rates of clearance of clinical cure as the first study, no benefit to adding sulfa. The most recent guidelines we have from the IDSA, the Infectious Disease Society of America, is from 2014. I think we're probably due for an update at some point relatively soon. They divided skin and soft tissue infections for the first time into purulent and non-purulent, which I think makes a lot of sense. Purulent infections are much more likely to be caused by staph than the non-purulent infections. But we are focused right now on this part of the of this chart, the mild to moderate non-purulent infections. So this is where cellulitis falls. And you can see that I have one of the recommendations highlighted here with a red box. And this is the recommendation for penicillin to treat this. And I'm going to caution everybody personally against this recommendation. Now, I don't think this was listed randomly. You'll notice it is not alphabetical, right? Penicillin is actually first, even though the next drug on the list starts with a C. So I think they are actually trying to imply that penicillin should be the first line therapy for these patients with simple cellulitis. And I'm going to caution everybody. So the reason they recommend penicillin is that they are making an assumption that the vast majority of simple cellulitis is caused by group A strep, not by staph of either sort, MSSA or MRSA. They cite 6 studies to back that assertion up. 5 of those studies are from before 1996, and they're all based on culture data. So it's before the age of MRSA really picked up, and based on culture data. Remember, only about 15% of cellulitis patients can ever be cultured, and it's probably a special 15%. Maybe they're culturable because it's group A strep. That's the dominant pathogen in that special population, but it does not generalize or tell us much about the other 85%. The 6th study is from much later, from 2010, and it used serologies, anti-strep serologies, and beta-lactam response to determine that strep is the dominant pathogen, not staph. They concluded that 73% of non-culturable cellulitis is caused by beta hemolytic strep. That was by the serologies. And they said the beta-lactam response was 95.6%. However, they didn't do intention to test analysis, and they had lost a lot to follow up without the serologies. If they had done intention to test analysis, the results would have come out around 51% beta hemolytic strep. The beta-lactams they recommended to get the beta-lactam response were cefazolin and oxacillin, both of which work beautifully on MSSA. Can't differentiate MSSA from group A strep with those 2 antibiotics. And this only included patients admitted to the hospital. So this is a special subset of patients that may very well not be generalizable to outpatients with simple cellulitis. So I'm not saying that it's definitely wrong to use penicillin, but I am suggesting that I don't use it and as first-line therapy, and that we should not assume that strep is the dominant pathogen at the expense of staph. And we can cover for MSSA at least much better with a late-generation semi-synthetic penicillin or a first-generation cephalosporin, which are also very cheap and widely used. So it's still a moving target, but the data is improving. For anything severe, admit those patients, monitor them, give them broad-spectrum IV antibiotics, debridement if needed. And I would argue that a beta-lactam is likely best for most simple outpatient cases. There's quite a bit of data that is true. And I would further argue that we should strongly consider a beta-lactamase resistant beta-lactam specifically, rather than a first-generation penicillin or second generation. Okay. Let's go to a very brief interlude. This is a small mini case. I'm going to show you pictures of a patient I was doing a skin check on. And he came in because his wife was concerned about a rapidly changing mole on his right abdomen. And you can see it there from a distance. Okay, over there. Okay, I'm going to show you a little closer, but I actually want to pause here and have you imagine that if I gave you no other information, if I didn't let you see it any closer, doorway diagnosis. What's your doorway diagnosis from the doorway? What are you thinking this might be? Think about it for a second, as though I could call on you randomly. Of course, I can't. And what procedures, if any, would you want to perform? What referrals would you make, if any? Okay, so doorway diagnosis, your best guess, procedures, and referrals. Okay, hopefully had a moment. I'm going to blow it up and show you a higher, more magnified, more resolute image here, okay? This is his changing lesion. There we go. Okay, so hopefully this has changed some of your minds about what this is. Whoever got it, congratulations, bravo. This is a tick, of course, and specifically it is an Ixodes tick. We know that. This is one of the ways to tell Ixodes from the other ticks. Ixodes is important, by the way, because it's the main carrier of Lyme disease, or it is the carrier of Lyme disease. There's a couple different species of Ixodes ticks, but they are the black-legged ticks. So at all their stages of their life cycle, they have black legs. That is, I find, the most reliable way to rule in an Ixodes tick. If they have brown legs, it's much more likely to be one of the other ticks, like the Lone Star tick or the dog tick, like Dermacenter. So Ixodes tick bite. My question here, well, I said Ixodes scapularis, by the way, in the Pacific side, on the west coast, it's Ixodes pacificus, but otherwise here in the east, it's Ixodes scapularis, the deer tick. Procedure here is a tick removal. Treatment is with doxy, 200 milligrams times 1, if the following conditions are met. So is it an Ixodes tick that can actually carry Lyme disease? Yes, in this case, it has the black legs. Has it been present for at least 36 hours? And either you can tell that by history, if the patient knows when they got it, or by the degree of engorgement. And this picture here is right about the 36-hour mark for engorgement. If you see a tick about that engorged, that's about 36 hours. And are you going to be able to prescribe it within 72 hours of removal? And yes, we're going to prescribe it immediately after removal. And they're hopefully going to take it very soon. So it meets all the criteria. So this patient would be an excellent candidate for a prophylactic dose of doxycycline to prevent Lyme disease. What about a referral? So I actually referred his wife, his spouse, to ophthalmology because she was still pretty convinced that this was a changing mole even after we started talking about this being a tick. So that was my referral in this particular case. There are a couple of good resources I want to draw your attention to. One is the CDC Tick Bite Bot, which gives instructions for how to remove the tick, to remind you, and also can help you determine whether the patient meets criteria for the prophylactic dose of doxycycline. So it's a useful resource. And then also this University of Rhode Island Tick Field Guide. It's I have no connection with them. I just like it. It's the best free guide I've seen online. It has lots of different pictures of lots of different ticks at lots of different stages in their life cycle. So it's a really useful way to help diagnose which tick you're dealing with if you're unsure. Remember that there are lots of non-Lyme tick-borne illnesses. Many of them respond to doxycycline, but not all of them. And so I've starred here the ones for which doxycycline is not the right treatment. Babesiosis is not treated with doxycycline. Powassan is a virus, one isn't treated with any antibiotics. Tularemia can be treated with doxycycline, but if you do that, it is a risk factor for persistence and relapse of the disease. So it's really not first-line therapy. And we do see tularemia here in the Northeast, where I'm pressing. It's rare, but it's not unheard of. I've seen a couple of cases in my career. And then this new alpha-gal syndrome that you have probably read about or heard about by now, this acquired red meat allergy is, of course, not doxycycline sensitive. That's essentially an autoimmune reaction. So the reflective statement here, remember that if it has black legs, it's likely at least able to carry Lyme disease. There's a resource there to help with tick identification. And you give prophylactic doxy for deer ticks that have been present for at least 36 hours. If they can take it within 72 hours of tick removal. Okay. Now, this next case is probably the most important case of the day. So the most important single point of the day is that cellulitis is tender. The most important case of the day is this one. So I'm going to show you pictures in a moment of a 52-year-old woman with lupus. She was immunosuppressed on mycophenolate mofetil and prednisone, and she presented unresponsive with a rash on her right lower extremity only. She had been fine the night before, and then she rapidly developed multi-organ failure in the ED. This is hospital day 1, what her right lower extremity looked like. You can see there. Okay. And then I'm going to show you hospital day 3. These are the pictures we're going to focus on, mainly because they're more instructive. It's a little bit easier to see the key features in these images from hospital day 3. I'm going to pause on this picture for a little bit. So I'll tell you the primary lesions here, as we like to talk about in dermatology, right? So we have here a bulla. You can see right over here, and there's a few others as well, filled with fluid. Where there are bulli, there often are or will be erosions, and sure enough, you can see an erosion here. So when that bulla ruptures, it leaves an erosion behind. And there are patches here. And patches just mean that there's color change without textural change, without it being raised. And I will tell you that some of these colors are purpuric. Purpura is not exactly a color, but when you press on it, it does not blanch. So you can't tell that with certainty from a photo. So I'm giving it to you. I'm telling you it is purpuric, at least the darker areas here. Now, I want you to think for a moment about what colors you see. And this is like a kindergarten question. I don't want fancy words. If I were asking kindergartners, what colors do you see? And if you were here in person in an audience, I might call on a few of you, have some colors, people and shout them out. So think about for a moment, see how many you can name. So I'll start to give you the ones that I see, right? So there's red over here. People often call red erythema. In this case, that's accurate, but I don't like it as much. Erythema has an etiologic connotation. And usually when we talk about erythema, we're usually talking about inflammatory causes of redness, whereas there may be other things like nobody calls it angioma erythematous, or very few people do. It's just red. So red is, it doesn't pigeonhole you into thinking about a specific pathophysiology. It just keeps the options open. It is red. You can't argue with that. There's redness here. There is also purple, violaceous color. Those are the same in dermatology. There is some black. If you look closely, look deep in this purple here. There are these black areas. And if we go back one slide, you'll see an area here that's much darker black. There's another color mixed in with this purple. It's a little tougher to see. And it's what we call in dermatology dusky. This is the only non-kindergarten term that I'm going to use here. And what we mean by dusky is that it's purple with gray or white or black ash spread on top of it. It's like ashy purple. So look here at this grayish color on top of the purple. Look here at this gray, black, or whitish color on top of the purple. A mix of some white, some gray, some black, but mixed on top of the purple. That's duskiness. It's a sign of impending necrosis. And then there's one more color here, which is, I think, the hardest to see. The closest thing we have here to her normal skin color is down here by her ankle, maybe up here on her calf. So this over here, this patch, this is not her normal skin color. This is white. This is paler than her typical skin color is. And I'm going to show you on the next picture just how starkly white this is. So in the next picture, this patch is going to rotate down over here. Okay? So that patch is now down over here. And it's the same color as this patch over here. And if you rupture a giant bulla off of that patch, you can see the dermis and see just how starkly white that dermis is. Porcelain white. What's the mechanism here of this whiteness? This is not, acute onset vitiligo or destruction of melanocytes, right? This is ischemia. It's white because it's blanching. It's not getting any blood. So the colors alone are beginning to tell us a story. We have redness, and in this case, it is indeed erythema. It's an inflammatory process of some sort, which is causing somehow or other ischemia, which is causing duskiness, early stage necrosis, and then black, late stage necrosis, and bullae as the epidermis quickly necroses off of the skin around it and below it. So the colors themselves are telling us a pretty good pathophysiologic story. But I would argue that the most important part to these pictures is actually the shape. And that's what I would like you all to start to notice and to leave this part of the talk understanding. So notice, let's go back a picture, back one slide. Notice these jagged edges, very well demarcated, separating different zones. Right? We have this red zone separated from this dusky zone by this very sharply demarcated, very jagged edged border. We have that dusky zone separated from this island of ischemia, this island of white, again, by this jagged, very well demarcated border. And you can start to see that pattern all throughout here. So what is going on here? What can that tell us about the pathophysiology? I'll ask a question here. In what anatomic structure does the primary pathophysiology lie? Where's the lesion, to borrow language from our neurology colleagues? Where's the lesion? Is it in the epidermis, dermal interstitium, the fascia, the arterioles, or the sweat glands? What can give us that shape in these colors? Give you a few more seconds. So the answer here is the arterioles. And I'm going to show you why. So this is a bit of a cartoon showing the vascular supply of the skin. In the skin, we have these perforating arterioles that come up perpendicular to the skin surface, and they branch out and supply a cone of tissue in the dermis. And that cone of tissue in the dermis corresponds to approximately circles on the surface of the skin. Those are the zones of arterial predominance on the surface of the skin. And in between those zones of arterial predominance are zones of venous drainage. Okay? I'm not a terribly good artist, but I've tried to draw this out schematically here in PowerPoint. So we have this perforating arteriole supplying that cone of tissue in the dermis, which corresponds to approximately a circle on the surface. Now, if you look at that en face, you have the circle, and where there's one, there's lots. And in fact, they cover our entire cutaneous surface. And in real life, they're not perfect circles. They're more jagged shaped, star shaped almost. We call these stellate patches, star shaped patches. The peaks and troughs average out to a circle, but they don't form perfect circles. And again, where there's one, there are many. And this pattern might start to look familiar to you. Each of these stellate patches is somewhere in the neighborhood of 1 to 3 centimeters in diameter, covering our entire cutaneous surface. Smaller than that on our acral surfaces, like our fingers and toes, can be just half a centimeter. And this is the reticulate or retiform or livido pattern that we see in dermatology so often, that net-like pattern that so many different rashes come out in. This is where it comes from. It's from this vascular supply of human skin. Okay. There's two main things that can go wrong with the system, broad categories of things that can go wrong. One of them is called livido reticularis. It's not really a problem most of the time. Livido reticularis, the most common cause is physiologic, is normal, and I'm sure some people listening to this talk get livido reticularis, especially on cold days or if your leg is hanging off a bench. It is from accentuation of those zones of venous predominance that outline those stellate patches. And you can see that it blanches. This was an accidental double exposure that from my camera that turned into a really useful teaching slide to show it blanching. Livido reticularis blanches because it's, again, blood in veins. They're just accentuated for one reason or another, and usually physiologic. But the other side of the coin, the other thing that can go wrong with this system is very different. It's called retiform purpura. It's almost the inverse of livido reticularis in some ways. It is purpura of the inside of those stellate patches from occlusion of that perforating arteriole supplying each stellate patch. Okay, so we have that perforating arteriole going up perpendicularly, and we put a clot in it for one reason or another. And we see on the surface ischemia, evidence of ischemia as it turns white, and then it begins to necrose. Maybe it necroses fast enough to form a bulla, and then we're left with rank black necrosis at the surface. And if you hit one single perforating arteriole, you have one stellate patch of retiform, net-like purpura, retiform purpura. If you hit multiple, you get multiple patches of retiform purpura, and they start to blend together. You lose the individual stellate patches, but you can still see that jagged border, very well demarcated. And you can still imagine where each perforating arteriole approximately lies. There's one over here, there's one over here, there's one somewhere over here, there's one somewhere over here, and so forth. Plus the individual ones that are hit, if they are separate. There's one in the middle somewhere here, one in the middle somewhere here. This picture is of a different patient. This patient had a vasculitis. And this picture is taken a few days after he was admitted, and everything is actually under much better control. His vasculitis is no longer active, but you can see the remnants of this retiform purpura from these ulcers, these crusted ulcers that now have to heal. And it just shows the pattern very, very well, which is why I've included this picture. You can imagine that all these perforating arterioles were hit, and then for whatever reason, the perforating arteriole or two that supplies this peninsula here was spared. That one's not involved. And then there's a few that were spared over here, and then one or two that were hit right here, and then a few more that were hit over here, and everything around it spared. So you have an island of retiform purpura here. You can see that jagged edge, very well demarcated. You can see here a solitary patch of a stellate patch of retiform purpura. It has that retiform, that net-like shape. Okay. So let's go back to our patient. You can see here, and hopefully this pattern is starting to look more familiar, right? See this patch of retiform purpura right here. Okay, hopefully more familiar now. You can see this pattern. Now we know why, pathophysiologically speaking, this patient has this eruption. Now, the patient's actual diagnosis is going to turn out to be the least important part of this case. But I'm going to take you through it anyway because the differential is very, very important. So remember, this patient had lupus. She was immunosuppressed, mycophenolate, mofetil, prednisone. She had terrible vitals on presentation. Temperature almost 105, pulse in the 140s, systolics in the 80s, unresponsive. She had acute on chronic thrombocytopenia, acute on chronic anemia, leukopenia, and renal failure. Very, very sick. So let's imagine what she might have. Okay, she has a clot in her perforating arteriole. We know that just by looking at her. We don't need any special tests for that. So what can cause a clot in a perforating arteriole? It must be either an in situ thrombosis or an embolism. If it's an embolism, it can be any embolism, cholesterol emboli, air emboli, amniotic fluid emboli, whatever it might be. I find it useful to further subdivide in situ thrombosis into vasculitides and hypercoagulable states. And then I further subdivide vasculitis into our traditional inflammatory vasculitis that we usually think of, but also into septic vasculitis to remind myself that angioinvasive organisms can cause vasculitis as well. So as soon as we identify retiform purpura, which we do with only using our eyes, we immediately know that that patient has an embolism, a hypercoagulable state, a septic vasculitis, or an inflammatory vasculitis. That's it. Now, that is a pretty broad differential. Granted, it's pretty big, but it's not infinite. And there's some useful characteristics that these entities share. So I'm not going to read the slide, but as you look through these entities on the differential, this is pretty comprehensive, not 100%, but it's pretty close. I want you to notice two things about these diagnoses on the differential. Number one, none of these are primary cutaneous conditions. These are all systemic diseases that to one extent or another might impact the skin. Okay. Number two, they're all bad. You don't want anything on this list, right? There's no good reason to have retiform purpura. Okay. And we know this patient has something terrible, right? She's gravely ill. But a patient might present to an outpatient clinic with a low-grade fever and one single stellate patch, one patch of retiform purpura on a finger. And they may not look that sick, but that is a Janeway lesion until proven otherwise. There's no good reason to have retiform purpura. Okay? Nothing on the differential is primary cutaneous. Everything is bad. Now, I said that her actual diagnosis will be the least important part of this case, although it certainly didn't feel like that when I met her at 11 o'clock at night in the emergency room. She was gravely ill, and I was really torn between three radically different diagnoses with three very different treatments. I didn't know if she had catastrophic antiphospholipid antibody syndrome, the so-called thrombotic storm that patients with lupus can get sometimes, or TTP, thrombotic thrombocytopenic purpura. She met all five key criteria. You don't need all five to make the diagnosis. She had all five. Or was this simply a systemic infection, either causing sepsis and DIC, or having a shower of emboli down to her leg, or a local infection that was rapidly spreading along the vessels in that lower extremity? Fortunately or unfortunately, very quickly, she grew out gram-negative rods from 4 out of 4 bottles of blood, and then had gram-negative rods on tissue cultures as well. And it turned out to be Serratia marcescens, and very unusually, it turned out to be a GI source. This is not what I want you to take away from this case. Serratia is usually a urinary pathogen. When it's not urinary, it's usually pulmonary. GI is a distant third. So Serratia marcescens sepsis with necrotic retiform purpura of a seated limb is what she had. It is not what I want you to remember. What I want you to remember is that retiform purpura is always a sign of something bad, and I want you to be able to recognize it from here on out, because this slips through the cracks. For some reason, it's not taught in medical school. The vascular surgeons don't deal with this because you can't find these clots on ultrasound. They're too small. These patients slip through the cracks, and if you recognize it, you can do a lot of good early on. So a few more faces of retiform purpura, a few more images. This is a patient who had had a vascular procedure a couple of days before this picture was taken, and this is the result of cholesterol emboli. You can see here that jagged edge, very well demarcated. Same patient here. A few more stellate patches over here, arterioles that were hit, one that was hit over here, and then for some reason this area that was mostly spared. Don't know why the emboli got some, not others, but that's what it did. The vascular surgeon, very good hospital, very good surgeon, was not familiar with this entity and thought because the ultrasounds were negative that this was not a clotting problem. This falls through the cracks unless you recognize it. This is a patient with DIC from E. coli sepsis, and this is her thigh. I showed you just the distal part of this image, you might simply be able to say that it's purpura, and that's a little bit helpful. Purpura can be helpful, but it's not that helpful, right? There's very benign reasons to have purpura. Bruise is purpura. But then if you look proximal and you see this jagged edge, these well-demarcated jagged edge here, and you see the jagged edge of this island of sparing in the middle, well, now you know it's not just purpura, it's retiform purpura, and that's a much more limited, useful differential. And then for bonus points, if you look carefully at this distal part, notice that there's two different zones of color here. There's a red area and a more dusky purplish area, and they're separated by very jagged edged, well-demarcated border. You can actually see the retiform shape even within this darkly purpuric area. Okay, look at her leg more broadly, and you can see those areas that are different with that jagged edge, retiform purpura. Another case of E. coli sepsis here. Another E. coli sepsis. Okay, just to give you a sense of what this all looked like. In this picture, I'm always a little hesitant to keep in because it's a terrible picture. It's totally out of focus. I had just gotten my camera as a first week resident when I got there, when I took this picture. But I keep it in because it proves the point that you don't need focus to diagnose retiform purpura. It's a 20,000-foot view diagnosis. This patient had a multiple hypercoagulable states that were stacking on top of each other to the point that she started clotting off these perforating arterioles. So you can see here this whitish center from ischemia and this purpuric border with that jagged edge. Retiform purpura, same patient here, different part of her body. So retiform purpura, recognize that pattern and that it's an early indicator. It's an indicator of a systemic, generally sinister. Malignant. I don't mean malignant as in cancer here. I mean malignant as in sinister process, dangerous process. I've got 5 minutes. I want to take you through a brief case. This is a fun one. So I'm going to show you pictures in a moment of an 18-year-old male with 1 day of a worsening pruritic rash on his face, and he came to the ED and was admitted into the observation unit for impetigo. And the next morning, the rash had extended toward his lip and his eye, and so derm was consulted out of concern for Stevens-Johnson syndrome because it seemed to be approaching his mucous membranes. Now, as I'm walking down to meet this patient, there are a few things going through my mind. Most notably, that the ED team is full of very smart, well-intentioned providers, and they're worried about this patient in some way that they're having some trouble expressing. Because we don't usually admit patients for impetigo, even to the obs unit, healthy adults at least. We don't usually give them IV antibiotics, and they don't usually turn, those patients with impetigo don't usually turn 12 hours later into Stevens-Johnson syndrome consults. So something funky is going on here. This is what the patient looked like. And you can see he is massively edematous, and he has this gold encrusting all over his ear and a little bit on his cheek. And indeed, that gold encrusting is a sign of impetigo. But healthy young adults don't just get impetigo out of the blue. Kids can actually just get impetigo, it seems like. But adults should get it because of something, because they are immunosuppressed, or because they have eczema that became impetiginized, or an abrasion that became impetiginized, something. So yes, this patient has impetigo, but we have to dig deeper. Why does he have impetigo? Okay. He's very swollen. He can't even open his eyes spontaneously. He can pry it open, so his eye is safe, but he can't open it spontaneously. He's so edematous. But he's smiling. He's happy. He's not sick. He feels okay. He's itchy. He's annoyed, but he's not sick. Let's look closer here at his ear. And I want to point out 2 things in this image besides his ear that are actually more important. One, my flash over here in the corner is shining back at us. It's an artifact, of course. It's my flash, but it's because his skin is wet. It's weeping. Number 2, in front of his ear, he's got these teeny, tiny little vesicles. Tiny little vesicles. They're not on a brightly erythematous base. This is not classic for herpes or zoster. They're very small for that anyway. So why does this patient have these teeny tiny little vessels bubbling out from his skin, leaking fluid that's making my flash shine back at us, and then allowing staph to feed off of that fluid and creating a secondary impetigo? And so when I have live audiences here, I sometimes, if they're big enough, I'm lucky enough to have somebody who speaks Greek. I ask if anybody speaks Greek. And specifically, if anybody who's listening to this, it's really ancient Greek. I learned from one of the audience members once. The root of the word eczema, what it actually means, because eczema is not really a diagnosis. It's a family of diagnoses. And it comes from the ancient Greek word eczema, which it means boiling over or bubbling out. And that is a characteristic of the acute phase of all different forms of eczema, that the skin, the fluid from the skin bubbles through the top layer of the skin. This separates the keratinocytes apart from each other. It's a process called spongiosis under the microscope, to the point that little microvesicles form on the surface, and the fluid, the serum, leaks out and makes the skin edematous and wet. And staph loves the serum and feeds on it, and so eczema often gets impetiginized. But as I said, it's not really a diagnosis. There's lots of different forms of eczema. So why does this healthy 18-year-old have eczema bad enough to get him admitted to the obs unit overnight for IV antibiotics? Let's look over the rest of his body for clues. Okay, we see some more eczema here on his axillae and on his abdomen. And then we start to see something interesting on his flanks. Notice these lines here, right? These are geometric shapes that our body doesn't know how to make by itself. This is eczema in perfect lines. Outside job. Something from the outside could cause these lines. And the most common cause of eczema from lines of lines of eczema can be an allergic contact dermatitis, and most commonly poison ivy, at least in this part of the US and many other parts of the US, poison ivy, very, very common. And in fact, so he was in the OBS unit, He didn't tell his primary team, but 40 feet away in the alpha unit of the ED was his girlfriend, looking exactly the same. They had been rolling around in the park the day before, apparently were in some poison ivy, and they both got really severe poison ivy. His team consulted derm, her team consulted allergy. The two of us met in the hallway between Alpha and OBS, exchanged notes, and sent them both home an hour later with some prednisone for 3 weeks, 3-week taper. So this was, and you can see here, she also has a line here that gives it away. Okay, so allergic contact dermatitis that became impetiginized. I'm going to skip this slide. I think I'm going to try to get in one more very brief case. We are at time, and so if anybody needs to leave, feel free. I'm going to take just 2 more minutes here. This is a patient who was admitted to the hospital that I met after he had been admitted for a day. A healthy 44-year-old guy who got something on his forearm a few weeks before this picture was taken, about 2 weeks before. He went to his uncle, who was a doctor, and uncle gave him cephalexin. Didn't get any better, so he went to his actual doctor about a week later and was given clindamycin. Didn't get better, so he came back almost a week after that and got a swab taken for presumed MRSA cellulitis, and was given trimethoprim sulfamethoxazole. Still didn't get any better, so he went to the emergency room and was admitted for IV antibiotics. You can see he started the IVs, and the plan was for a PICC line for 2 weeks of vancomycin for presumed MRSA cellulitis, and he actually insisted on the derm consult. So I met him at that point. Now imagine for a second, this is why I wanted to do this case now. Imagine that you are the doctor in the room and you get paged out. You have to run. You have time for one piece of information, to collect one piece of information, whether it's from a question, so history, or a physical exam maneuver, or ordering a lab, but you only get one. What are you about to do? And after you leave, if you don't stop it, this patient's going to get a PICC line. So what I did, I mashed on his arm. I introduced myself, I asked permission, and then I mashed on his arm. Not painful, did not hurt. It is not tender. So it is not cellulitis. Abort the PICC. Okay, number one. Then you have to sit and ask what this actually is. Okay, so let's look a little closer here. We have this edematous plaque. It is eroded in the center, and around the erosion are teeny tiny little micro erosions. There's some gold encrusting around as well, so staph likes this. Now, these teeny tiny micro erosions, where you see those, there probably were teeny tiny little microvesicles before that ruptured. So what causes edematous, erythematous plaques with microvesicles that erode and rupture and leak serum that staph eats? Eczema. And specifically in this case, it is, again, I'll give you the answer, an allergic contact dermatitis. To what? Well, what do we do when we have something on our arm that we think is an infection and our uncle, the doctor, gives us cephalexin and it's not working? Many of us put on triple antibiotic ointment, which has bacitracin, which is one of the always top 10 most common causes of allergic contact dermatitis in the country, and neomycin, always top 5 causes of allergic contact dermatitis in the country. So 2 of the top 10 in triple antibiotic ointment. This was a rip-roaring allergic contact dermatitis to triple antibiotic ointment, and he went home happily an hour later with clobetasol and did great. This last patient here, very similar story, had been in the hospital for a week with otitis externa, and this ear is twice the size of his other ear. And this was another case of severe allergic contact dermatitis to triple antibiotic ointment. I don't know if he had otitis externa originally or not, but his family had done their research and learned about it and learned it's often caused by Pseudomonas, which often responds to antibiotics such as neomycin and colistin, also known as polymyxin B. And so they had been sneaking in his triple antibiotic ointment and applying it to his ear 5 or 6 times a day. He went home an hour later with clobetasol as well and did great as well. So I will end there, and I thank you all very much for your attention. Remember, impetigo in a healthy adult should prompt deeper inquiry, and triple antibiotic ointment is a very common cause of allergic contact dermatitis. So thank you all very much for your attention, and I'm sorry I went a little bit over.